Hello, I hope you can all hear me. Thank you very much indeed to the organisers of this excellent meeting, and indeed to keep this talk is Optimizing Biologics in the Management of Ulcerative Colitis. So in this talk, what I'd like to cover is reflect on the unpredictable course of disease in ulcerative colitis, think about the therapeutic goals in ulcerative colitis and indeed how they are evolving over time. Then look at management and treatment strategies for these patients and very much focus on how to choose the best option for any patient. And of course, within that, having a holistic approach to the patient. So, of course, when we first meet our patients, it's very difficult to know how their disease will behave over time. So some patients can have an initial flare of disease, but actually their disease is fairly quiescent thereafter. The majority of patients have disease like in the bottom two graphs, either a chronic continuous disease or indeed a chronic intermittent type of disease course. But it's very difficult initially to know how patients will behave. What are the predictors of how disease is going to behave? Well, maybe there are some clinical predictors, and one is endoscopic severity. And I think we all know as clinicians, if we look into the bowels of these patients and their disease looks very endoscopically active, that predicts poorer outcomes for these patients. Also, extensive disease at diagnosis. So it's fairly intuitive, but patients who present with a total colitis or pancolitis, rather than just proctitis or left-sided disease, are more likely to have worse outcomes over time. But the third group down is another important group, and that's a group of patients who extend their disease over time. So this is a group who maybe presents with a proctitis or a left-sided disease, but over time their disease does worsen. And of course, youth is another risk factor, mainly because they've got a lot of years of their disease henceforward, which needs managing. And I'm just drawing your attention to one study on the right-hand side, which is not a clinical factor, but a blood-based prognostic marker. Now, this marker is actually being used in a clinical trial currently in Crohn's disease, but a very similar signal was actually found with ulcerative colitis as well. This was a transcriptomic marker in CD8 positive T cells. And of course, this is not ready for prime time yet, but certainly it's worth just considering that there are potentially some biomarkers coming down the pipeline to help us actually appreciate how disease may behave over time. So moving on to goals of therapy. Well, of course, the major goal is that patients are genuinely well, and that means we want them to be better clinically, but also endoscopically. So we want their mucosa under the endoscope to look better. And you see there is more and more data pointing to histological improvement as well, being related to better outcomes over time. And I think maybe one of the factors which is often forgotten is the psychological well-being of patients as well. So I put that in the goals of therapy. And of course, all of this has got to happen without the side effects of therapies. And maybe another way to look at these goals is this particular slide. So going from the bottom circle up, decreased symptoms, of course, important. A really important goal is to get these patients well and off steroids. And I think if we all audited our own practice, we may be surprised that there is often a lot of surreptitious use of steroids in this population still. So really important to get these patients well and off their steroids. We've talked about mucosal healing, and of course that I think is linked with the mitigated risk of colorectal cancer or dysplasia. And a lot of patients will often put stomas in particular, but operations is something they really want to avoid if possible. And right at the top of this list of goals of therapy, I've got quality of life, and I think this for sure is one of the most important goals we all need to absolutely focus on. So these are maybe some of the words that we think of as clinicians. Our patients may, however, have very different goals when they think about what they want to achieve. They might just want to get on with their career or their home life or whatever it is. And I think it's still really important to make sure when we talk to our patients that we can really make them appreciate that some of those words that we use as clinicians can absolutely achieve their goals as well, and really try and make these Venn diagrams overlap as much as possible. So just a question for the audience to ponder on, and I'll show a little bit of data. And it's a question about, is ulcerative colitis a progressive disease? So yes, no, or don't know. Well, let me show you a little bit of data. This is data which shows UC disease extension from limited disease diagnosis over time. And you can see that round about 1 in 5 patients will extend their disease over time. So for sure, it is progressive in a certain group of patients, And indeed, that progression is associated with worse outcomes, as I've already mentioned. Maybe another aspect of UC is some of the common findings that we find endoscopically of maybe a tubular colon with that loss of haustral patterns, or a narrowed, shortened and stiffened colon when we look at it endoscopically, and occasionally strictures. So I think there is some evidence that in some patients, ulcerative colitis is progressive, but I would also maybe challenge the audience that in some patients it's not progressive, and those patients can generally get just the occasional flare, and actually their mucosa comes back to normal thereafter. So I think maybe the answer to the question is in some it's progressive, but not in all. But what about the art of managing these patients? Well, I think it's all to do with what's displayed in this particular slide here, and that's getting the right balance. So what we don't want to do is undertreat patients who are likely to have the difficult disease. On the other hand, we don't want to be overtreating patients who have the minimal disease, maybe with just a very isolated flare with minimal impact overall on their quality of life. So what are the treatment options for UC? Well, of course, broadly, they can be divided into these two groups: induction agents and maintenance agents. And you can see that all the drugs are in both groups, with the exception, of course, of corticosteroids, purely used for induction, but not for maintenance therapy down the line. But let's now consider a case. So this is a case of a man who's 25 years old, and he works as a builder. He's single. He has distal colitis diagnosed in late teenage years, so very difficult disease to deal with. And he's initially prescribed topical and indeed oral 5-ASA drugs. He has ongoing difficult symptoms with urgency, diarrhea with blood, and you can see some of the inflammatory markers are raised in addition to the fecal calprotectin. So he's given a course of corticosteroids with some improvement, but has another flare, so comes to more steroids, and then thiopurines are started with low levels noted. So he's escalated to adalimumab. He doesn't want to attend for intravenous dosing. But I'll just ask you to think, if you were looking at this patient in your clinic, what do you think is really going on in this case? Well, I think it's the sort of case where adherence to their medication is an obvious thing to really think about and ponder on. And educating patients about the importance of adhering to their treatment is such an important part of managing. I think I'm always surprised to see that actually 70% of non-compliance is intentional. That means patients know what they need to do. They just opt not to do it because they don't really understand the reason why. So you can see in this particular table that the strong evidence for non-compliance is potentially beliefs about the illness, the necessity for the treatment, maybe the perceived effect of the treatment, or indeed concerns about side effects. So taking time to really explain these is a key part of management. But let's now consider another case. So this is an older man, a 47-year-old man with total colitis diagnosed at the age of 37. He's taking his oral and topical 5-ASA very well. He's had a previous course of prednisolone, and he's tried azathioprine, but said he was intolerant to it. He has chronic active symptoms, as you can see there. And again, the bloods are normal with the exception of the raised inflammatory markers and calprotectin. And you can see from his endoscopic appearance, clear evidence of active disease. So if you're seeing this man in your clinic, what would you be thinking of? Would you be stretching for one of the anti-TNF drugs, infliximab, adalimumab, or golimumab? Or would you be moving on to first-line therapy with vedolizumab, or tofacitinib, or ustekinumab? So have a think what you would do, and we'll think about some of the data that we have. So of course, options now becomes more and more difficult as that menu and list gets longer. What head-to-head data have we got? Well, as Ryan mentioned earlier, and was mentioned in one of the talks earlier, there was the VARSITY study, which of course is the first head-to-head study with adalimumab in ulcerative colitis patients. And you can see the primary endpoint of clinical remission at 1 year, with vedolizumab being superior to adalimumab. But are there any other ways that we can maybe think about what is the best option to choose? Well, this is data which is trying to look at that. And what I'm showing you here is what's called Supra ranking for induction of therapy. In the left-hand panel, this is patients who are biologic naive. And in the right-hand panel is patients who've experienced anti-TNF in the past. And the length of the bars in each of these particular groups gives, if you like, the Supra level, which is the percentage efficacy achieved by that agent if you compared it with an imaginary agent which had the best outcome. So if you like, the higher Supra score would correspond to a higher ranking for induction of that drug. So you can see in this left-hand panel that infliximab scores very well for a primary drug, but the other drugs are also scoring highly. What about in patients who've had an anti-TNF? Well, ustekinumab and tofacitinib certainly would rank highly as options in those treatment groups. I think the problem with some of this data is, of course, that we don't have the detail. So the issues regarding the reason for the anti-TNF exposure or failure really aren't dug into in these particular data sets. So what factors do determine choice? Well, route of administration is certainly becoming a major one, and this has become very apparent during the pandemic, when a lot of patients didn't want to attend a hospital for an intravenous infusion. So subcutaneous options, or indeed oral options, were often preferred by patients. Speed of onset is, of course, an important consideration, and very important that patients want to get better and feel well very early on. A very important factor, I think, as well, is potential immunogenicity, or indeed the need to have combination therapy. So the anti-TNF drugs in particular often need the helping hand of the thiopurines or sometimes methotrexate to really get the optimal benefit out of them. And of course, coupled with that is the side effect or safety profile, where two drugs tend to be riskier than one drug. Very important, I think maybe a major driver of our decisions is comorbidities. So if the patient has had other particular issues with their health, or previous cancer, or previous infections, or indeed have extraintestinal manifestations, that can certainly impact on the therapy choice for patients. I think another factor which drives decision-making is the durability of effect. And certainly one of the issues we have with anti-TNFs is that patients can lose response over time. The availability of infusion facilities is, of course, important, as is the overall cost. So if we go to that patient that I showed you, this is the 47-year-old man who had been given azathioprine and was intolerant. Well, this was a man who was actually very risk averse. One of his parents had had a lymphoma, and he was very anxious about even taking the thiopurine, and he was very anxious about risks of systemic immunosuppressive drugs. So he was treated with vedolizumab, and that was his first drug. One word of caution, I think, particularly as we get more and more drug options for ulcerative colitis, and that is that we can fall into a trap as gastroenterologists, cycling through different options. So potentially patients could have 1, 2, or even 3 anti-TNFs, all optimized, then move on to different drugs like vedolizumab, tofacitinib, or ustekinumab. But I think a key question to always ask ourselves and make sure we're really asking it of our patients is what is actually happening to that patient during this time. Are they resetting their threshold for what's acceptable quality of life? And maybe are they normalizing a poor quality of life? And make sure that action in time. And that might include actually surgical options to make sure that patients are really aware of that. One way of doing this is a joint consultation. So this, to my mind, isn't the gastroenterologist and the surgeon sitting in different rooms, maybe across a corridor, but sitting in the same room together with the patient and any family members to really make sure at any cross-section in time that a patient truly understands the risk-benefit of another drug option and indeed the risk-benefit of a surgical option, to make sure a consistent message is delivered to a patient. And certainly patients give feedback that they like this sort of service delivery and way of delivering care. So to go back to the case was maintained on vedolizumab, and he did very well for 2 years. But then he started to get some breakthrough symptoms at around 6 weeks after the infusion. And again, some of the inflammatory markers were mildly elevated, as you can see. He had no infection on stool testing. So again, just think, what would you have? Would you want to look at the colon? Would you want to check a drug level of vedolizumab? Would you maybe optimize the vedolizumab by shortening the interval? Or would you switch to a different drug, an anti understand whether if a patient had had vedolizumab first line, whether going back to an anti-TNF second line would be a good idea. But this data that Brian Bresler presented a couple of years ago now shows that if an anti-TNF is used second line, it's fairly comparable to if the anti-TNF is used first line. So maybe for a patient like the one I've shown you, it wouldn't be an unreasonable thought to go on to an anti-TNF if that was the patient's choice. However, what is often done in this sort of case, and what we did, was we escalated the vedolizumab, and indeed the patient regained response. And the patient asked about stopping their therapy. Again, a very common question by patients to see if they can actually get some time off their therapy. So what would you do now? Well, is there any data with data experience? And it very much parallels the sort of data we see with other biologics. So patients for sure are at risk of a flare and difficulties if they come off their biologic. But again, analogous to anti-TNFs, if you reintroduce the same therapy, the vast majority of patients will respond to that therapy. What happened with this particular case was we did a colonoscopy to see if actually it looked like there was good healing. And actually there was a surprise here, because particularly in this case, and we do find this when we scope these patients, some invisible low-grade dysplasia was noted. So a question asked by the patient when you see this sort of appearance, and the patient's quite well clinically, is what is the risk of finding this sort of problem when you see this in the bowel? What's the risk of progressing to a high-grade dysplastic lesion or cancer? What is the risk they might actually have a cancer there at that time? And really importantly, how are we communicating this risk with the patients? Because of course the options here are ongoing surveillance, which is what this patient opted for, versus surgery. And indeed, if surgery, the type of surgery, and what do we do with the biologic drug? If we turn to guidelines, and I'm showing you here the ECHO guidance from 2017 and the scenic guidance, it actually is quite unclear what to do with these sorts of cases of invisible or indeed flat low-grade dysplasia. It very much says to personalize the decision. So let's look a little bit more data, and this is data that we produced from St. Mark's just a while ago, and it looked at the prognosis of IBD dysplasia in the very much more up-to-date video endoscopic era. So this was an updated review, and we did a systematic review with meta-analysis. And what this showed was that if there was visible low-grade dysplasia or indeed invisible low-grade dysplasia, the pooled estimate prevalent cancer rate was pretty low at 3%. One thing just to think about is how we talk to patients when we see this sort of finding. I think it's a very difficult conversation, because a patient might say, well, what are my chances of getting cancer, for example, in the next period of time? And I'll just direct you to this particular tool that we're developing at the moment called the UC Care tool. And what it does is it asks for various features of the patient and indeed the lesion that is seen if low-grade dysplasia is noted. And it comes out with this sort of paling chart, which can very visibly help a patient understand what their risk is at various time intervals, to help with that difficult decision about whether to continue with surveillance or indeed go on to surgery. So just by way of summary, we certainly have an increasing list of choices for patients with ulcerative colitis, but I think this adds to the complexity of managing outpatients with colitis. Always very important not to forget the basics, as I demonstrated in that first case, really making sure a patient is educated and understands the importance of adhering to their therapies and making sure the first choice of biologic is important. And I think a key is early assessment of response to make sure that you're on the right track, and if not, then something can be changed relatively early on. The reason for failure for the first biologic is for sure important and likely to influence future biologic choice. I certainly think we need to aim for shared decision-making to get it right for every patient in this personalized strategy approach. And for sure, we need more pragmatic head-to-head studies in biologic naive and experienced patients. A final point to make is remember that not all symptoms of diarrhea or urgency or bleeding or indeed pain are due to inflammation, but nonetheless, they're very important symptoms for the patient. As we've heard in a previous discussion about managing functional symptoms, they need to be listened to and addressed very carefully. And a word of caution, not to let quality of life slip. Remember the role of well-timed surgery. I thank you very much indeed for your attention and thank you for listening.